The last thing I will say for those of you who have test-taking anxiety, this can be your last major test, unless, of course, you're going on to fellowship, because for the internal medicine boards, for your renewals, you'll actually have a lot of flexibility, and you don't necessarily ever have to take a long sit-down test like this again. You'll have an option to do an open book mini tests in the future when it comes time to renew your boards. So, for some of you, hopefully that is very, very happy news to hear, because I know taking tests is not all of our favorite activity. So with that, I think we are ready to start on our last talk of the day. I want to welcome Dr. Renzel, who is joining us all the way from our Arizona chapter of ACP, who very graciously has stepped in to help give a diabetes-focused talk. As we already saw with the blueprint cardiovascular topics, of which diabetes has a lot of overlap, as well as some endocrinology topics, of which diabetes is the largest one, there is a lot of diabetes and diabetes-related content on the exam. And of course, no matter where you find yourself in internal medicine, you will deal a lot with diabetes. So without further ado, I will turn it over to you, Dr. Renzel.
Thank you, Dr. Shinoy. Can everybody hear me? Okay. Awesome. And actually, I am renewing my boards. I took them initially in 2016, so I'm up and I'm doing the LKA assessment. So if anybody has any questions about that, I can certainly talk about it at some point, or you can email me. But I am a hospitalist at Mayo Clinic in Arizona, and I have been talking about diabetes in a roundabout way since 2016. And I also had gestational diabetes when I was pregnant with my first daughter in 2018. So I've lived it, and I've also talked about it quite a bit at various different conferences all around the United States. This talk is adapted from an inpatient diabetes management talk. There is some outpatient management. As I was talking with Dr. Shinoy before the conference started, the principles are essentially the same. So we're going to do a case-based format. Maybe if my slides advance, or we're not. So we're going to do a case-based format to understand blood glucose targets with a focus on patients' comorbidities. We're going to discuss how to initiate insulin using weight-based and A1C targets, also based on patient comorbidities. And then we're going to discuss non-insulin anti-diabetic medications. If you have any questions during the talk, please put them in the Q&A. And we're not going to use any polls. We're just going to do this in a case-based format. The questions are open-ended. If you want to put forth an answer, please do into the Q&A box. Their answer key will be up for you on your course website after the talk today. So this is case number 1, the 52-year-old female. She comes to the emergency department with chest pain. She's obese with a BMI of 32 and has a history of hypothyroidism, hypertension, and dyslipidemia. She takes levothyroxine, amlodipine, and atorvastatin. Her last visit to her PCP was 18 months ago when she had labs that were normal at that time. When she presents to the emergency room, she's hypertensive to 160/95. Her labs are significant for a creatinine of 1.5, a BUN of 24. Troponins are elevated but flat at 75, 72, and 65 respectively. Chest X-ray is normal. EKG is normal sinus rhythm with no ST&T changes. Her glucose on her basic metabolic panel is 175. She is admitted to you as a chest pain rule out. So if this were a patient presenting to you and you were the admitting hospitalist, what would you do, if anything, to work the glucose up further? Any thoughts on that? And with regards to inpatient glucose control, do we have targets? And how would you manage her blood sugar during her hospitalization? So essentially, these cases are going to take you through admitting a patient, managing a patient, and discharging a patient, and then outpatient management. And that's pretty much the flow of the cases through this talk. So does anybody know any thoughts on what they might want to do with this patient?
We have a request for an A1C.
Great. Okay, so you want to check an A1C. Does anybody have a target in mind for glucose control for this patient when you're admitting them to the hospital?
Well, it looks like we want to target a 140 to 180. and would recheck tomorrow's labs. But we're getting a lot of 140s to 180 range target.
Great. Would you right off the bat try to do something with her glucose? Would you try to treat it right off the bat? You think we need to treat it? Anybody have real life experience? This patient is, I think, comes into an ER every single day in the
Yeah.
United States.
We're getting, we would let it ride for now. Focus
I like
on,
that because that's in practice what I would do too, right? So practice is different than boards, which is different than guidelines. So it's all kind of clinical gestalt. But yes, I would probably let it ride. But this is the ADA 2026 guidelines in terms of what to do with a patient who presents with hyperglycemia to your emergency room who's being admitted to the hospital. Now, I'm not talking about ICU patients. This isn't a critical care conference. So this is really focused on non-ICU hospitalized patients. So hyperglycemia is defined as any blood glucose greater than 140. We all learned that in medical school. The guideline recommends you perform an A1C test on all people with diabetes or hyperglycemia, which is a random blood glucose greater than 140. So remember, I did not tell you whether she was fasting. I didn't say anything about the BMP. I just said her blood sugar was 175. So whoever answered A1C is absolutely correct. The patient did not have a history of diabetes, probably hadn't had an A1C in 18 months. So I would definitely check an A1C. You can forego the A1C if it's a known diabetic or somebody who's had an A1C available to you from the last 3 months. So in terms of initiating insulin, a lot of you mentioned that 140 to 180, that is kind of the magic sweet spot where we think, okay, maybe we should initiate insulin in patients when the blood glucose gets between 140 and 180. The actual guidelines say that if the blood sugar is greater than 180, and you have to confirm this on 2 occasions within 24 hours. So the person that said they'd let it ride was actually correct. So tomorrow morning, or you could do a point of care glucose Q4 hours, which is in the guidelines, to see if you get another blood sugar that's random that's greater than 180. So that point, you're going to initiate insulin, and I'm going to talk you through about how you would do that. And conversely, you're going to treat any hypoglycemia as a blood sugar less than 70. At my particular hospital, we always add the hypoglycemia protocol to most patients because they don't eat, and it allows the nurses, it's nurse driven, it allows the nurses to act if they do have a hypoglycemic event. Target blood sugars changed over time. So this was a little bit surprising because in 2024, 2025, until the most recent guidelines, they had said 140 to 180. And then actually in this most recent guideline, they were going all the way down to 100. And I will tell you that some patients will feel hypoglycemic at 100 because they're used to their blood sugars being a lot higher than that. And I rarely target 100, but this is the new guideline. Of course, avoiding that magic number of blood sugar less than 70 or hypoglycemia. For a lot of my patients, they are terminal or have a limited life expectancy or at high risk for hypoglycemia, and we'll go through those conditions that make patients at higher risk for hypoglycemia. Target range less than 200 milligrams per deciliter is okay. That's actually my target usually in clinical practice. I don't get too excited if they're, 170. If you have patients that your morning BMP or who you do fasting labs with in the clinic and you see that their glucose level is less than 100, that's a large predictor of hypoglycemia within the next 24 hours. And so if you are seeing that patient in the clinic after they have labs that morning, or if you're seeing them in the hospital after they get their AM labs, you want to make some insulin adjustments, or else you'll be likely to have episodes of hypoglycemia when you see that. So let's talk about the second bullet point, which is how do we initiate insulin? The guidelines are the same for inpatient versus outpatient. This is actually an inpatient algorithm that I love. This was developed in the, I would say, 2016, 2018 timeframe by the Society of Hospital Medicine. It really hasn't aged out. The ADA has offered new guidelines, which I will show you for their most recent 2026 release. But I use this. This is the Society of Hospital Medicine. So this is really applies to all type 1 diabetics. We're mostly going to talk about type 2 diabetics during this conversation today. Should have scheduled basal insulin. So how do you do this? You can use their patient characteristics and their medical comorbidities and whether or not they're eating. And that's pretty much the three things that I look at when I'm trying to determine how I'm going to dose a patient's insulin. So estimated total daily dose, you can see malnourished or elderly, meaning greater than 65, chronic kidney disease / end-stage renal disease, end-stage liver disease, 0.2 to 0.3 units per kg. I've never seen this done, but those then do outpatient may have seen this done, so 0.1 units per kg or a DDP4 inhibitor or a DDP4 inhibitor plus basal. I've never done this in my elderly patients that are admitted to the hospital. But that is one of the Society of Hospital Medicine recommendations. Your normal weight patients, including your type 1 diabetics, you're going to be at 0.4 units per kg. Your overweight patients, so BMI greater than 25, you're going to be 0.5 units per kg. And then your obese patients who are on high dose steroids or have insulin resistance, you'll be at 0.6 units per kg. I rarely ever start on 0.6 units per kg. There's a lot of factors, and I'm a hospitalist, like I said before, so there's a lot of factors as to why I don't do that. We make patients NPO all the time, then we give them food, and then we don't give them food. They don't eat as much. They have impaired function of multiple organs, and so I tend to avoid the high 0.6 units per kg, but I think in outpatient with a patient that's stable, that would be appropriate for those that have high insulin resistance or are on high dose steroids. So again, moving on, this is also Society of Hospital Medicine. So we kind of discussed how you would dose the insulin based on the patient's age, clinical characteristics. So now this is going into how you would dose insulin based on how the patient is eating. So NPO or clear liquids, basal, we give 50% of the total daily dose. Obviously, short acting or nutritional, you're going to give none, and sliding scale insulin if needed. Remember, this is for patients admitted to the hospital. So oftentimes my residents will say that they're going to this is dogma. It's been carried on for years and years and years, that they're going to take the patient's current Lantus dose, they're going to half it, and that's what they're going to give them the morning of surgery. But if you actually read the guidelines, you're only supposed to take that half of the total daily dose, which is what they should be on for their long acting anyways. The easiest calculation here is, of course, if they're eating all 3 meals a day. So you're going to give them their basal at 50% of the total daily dose, and then you're going to divide the remainder, which is 50%, by their 3 meals and give them sliding scale. This is what you would do with patients at home who are going to be eating. If you have patients in the hospital that are on continuous tube feeds, you can see there's a variety of ways to do this. Each hospital system will do it differently. And you can choose to do it based on the amount of carbs that are in the tube feed formula. You can just use correctional insulin, or you can even put insulin in the bag. So it kind of depends on what your hospital system is and what your dietitians will be recommending. Typically, I will say in our hospital, we put 10 units of glargine, and we go with that. And then we use the correctional Q4 rapid acting insulin, and then we see where we land. In terms of bolus tube feeds, think of this as very similar to as if the patient's eating. Remember, they're going to bolus themselves 3 times a day. So you're going to use your basal as you would have calculated based on the patient's weight and medical comorbidities. And then you're going to dose it based on a carb ratio of 1 unit per 10 to 15 grams of carbs prior to feeding. This is also what you can do if you want to do that for the nutritional, though it becomes more difficult. And as Dr. Shenoy and I were talking about before you guys came on, when patients have poor health literacy, using the carb count can be very difficult for them. So it's often a good starting point to use their weight and do the weight-based dosing. Parenteral nutrition, again, you can add the nutrition to the bag, insulin to the bag. Usually they add regular insulin based on the formula that's being used for parenteral nutrition. And typically what we recommend in the hospital, because it's rapid titration, obviously in the clinic, it's going to be a little bit slower. A patient's going to have their glucose log, and you're going to be doing it per their visits. We adjust every 1 to 2 days based on the glucose trends and decrease by 20% if hypoglycemia. And typically you're going to increase by 10 to 20% if they have hyperglycemia, meaning their blood sugar is greater than 180. So this is the 2016 updated guidelines by the ADA for dosing insulin. This is all pertains to type 2 diabetics. And so this actually uses the hemoglobin A1C, which is also something that you can use versus using their kind of medical comorbidities. So I still think the medical comorbidities really play a big role. And I think that's because I do admit patients who have a lot of organ failure. And so I am, constantly making adjustments to their insulin regimen. But starting doses based on their body weight, hemoglobin A1C by the ADA is A1C less than 8%. You're going to start at a low amount of 0.1 to 0.2 units per kg per day. A1C greater than or equal to 8, you're going to start at 0.2 to 0.3. And then severe hyperglycemia with catabolism, you're going to use 0.3 to 0.4 units per day. And again, that's usually going to be your type 1 diabetic. They're very catabolic, or patients that are obese that have a high level of insulin resistance. Alternative approach, which I sometimes use in the hospital, is just to start with 10 units a day, regardless of their weight, and then titrate. In the hospital, you titrate every 2 to 3 days, depending on the type of long-acting that's available at your hospital. And again, they're looking for tighter glucose control on this updated guideline, which is 110 to 130 without hypoglycemia. So oftentimes, I don't know if any of you who work in hospital medicine, what we will commonly see is sliding scale insulin monotherapy. This is still not recommended by the ADA or the Society of Endocrine, or the Endocrine Society, excuse me. And they recommend that you really go with basal bolus insulin dosing. I will say there have been a couple studies. The last one that I read was in 2021, and there was the patients, they put them on sliding scale insulin monotherapy and they did okay. Sometimes we do this in the hospital. I think this is very practice pattern dependent, where we will just put people on sliding scale. One advantage of putting people on sliding scale insulin is that you can calculate how many units they require in a day, and then you can actually take that amount, and the next day you could pull that forward and do a basal bolus regimen. So there is some benefit to it. But just for you all to know that is not a recommended monotherapy at this time. So for a board style question, you'd never pick sliding scale insulin monotherapy. And again, looking at basal dosing. So remember that if you're not getting to target and your basal dose is pretty high, then that's when you would consider adding prandial insulin. Most of these patients will already be on oral anti-diabetic medications at this point. Again, in type 2, you could just start with 4 units. Again, you could just pick 10 units for the long acting and pick 4 units at meals and then titrate. Again, 10 to 15% per day in the hospital. So I like to use the weight-based dosing, but again, you can also pick 10 units for long acting and 4 units with your aspart or your short acting, and go from there and see how your patient does. Type 1 diabetes, again, as we talked about, 0.4, that aligns with the Society of Hospital Medicine. But a lot of times they're on 0.5 units per kg per day. Again, that's the catabolism that you see with type 1 diabetics. We talked about that higher doses will be needed in obesity, but also through pregnancy and sometimes in acute illness, and through puberty. So just keeping those stages of life in mind. Lower doses are recommended for older adults. Again, we talked about renal failure, malnutrition, low BMI. Low BMI is defined by the ADA as a BMI less than 19, so they don't have to be underweight, but they have to be on the thinner side of the normal BMI to consider doing the lower dose of insulin. And remembering that our basal insulin typically in type 1 diabetics is going to account for 40 to 50%, with the remainder as prandial, and that's exactly the same as for type 2 diabetics. So Endocrine Society, also weight-based dosing, very similar to the Society of Hospital Medicine. Again, you're seeing a similar theme with the basal insulin and the prandial insulin. And they recommend the same as the Society of Hospital Medicine. And if your patient's NPO, you hold the prandial and continue the same correctional dosing. Okay, let's talk about case number 2. So this is a 75-year-old male veteran. He has history of diabetes and chronic kidney disease. He presents to the clinic for a diabetes follow-up visit. Prior to arrival, he had fasting labs done, which show a blood sugar of 200 and a creatinine that has increased from 2.5 from his baseline of 1.8. His home insulin regimen is 15 units, 70-30 of Novolin twice a day, and a regular insulin sliding scale as needed for blood sugars greater than 180, which he usually uses at lunch and dinner. For the past week, he's been feeling shaky, diaphoretic, and weak, especially after lunch and dinner, such that he's needed to eat a high carbohydrate snack. He checked his blood sugar around 3 p.m. yesterday and it was 55. He tells you that he's been taking his BID insulin doses closer together because he has been very tired and he usually sleeps till about 10 a.m. So what factors do you think are contributing to this patient's hypoglycemia? Who's seen this veteran before? I know I have. This is actually a real case of mine. So that's why this is my only real case that I brought in, but this is a real case. What do you think contributed to his hypoglycemia? And what is this premixed insulin that I brought forward? Has anybody heard of it?
One of the ideas as far as what's contributing to the hypoglycemia is decline in renal function.
Absolutely. Okay, so insulin is cleared through the kidneys, right? So if we have impaired creatinine clearance, our insulin hangs around a lot longer. We don't need as much, which is why you'll see a lot of patients who have end-stage renal disease say, hey, I'm not diabetic anymore. That's not true. They often have metabolism issues related to their renal failure, and they have alterations in their glucose metabolism. So yes, the acute renal failure is definitely contributing. It's decreasing the creatinine clearance and decreasing the ability of the insulin to be excreted. And so it's going to hang around a lot longer. What else do you think is contributing to this patient's hypoglycemia? Because that is not the only thing. Or maybe the easier question is, what is Novolin 70-30? So I think when you know what's in Novolin 70-30, then you'll know why.
Another point about the timing of it. They're bringing up that he's taking his insulin later in the day. They may be alluding to then to the ratio of the NPH versus the regular in the mix.
Yeah. So I brought this up because I used to work with a veteran population. I used to work at the VA here in Phoenix. Yeah, absolutely. So timing of when he's eating and when he's taking his insulin. So premixed insulins are cheap, and a lot of the veterans were on premixed insulins. The thing about premixed insulins is you have to eat at the same time every day, and you can't skip any meals because of the way that they work. So Novolin 70-30 is 70% is your intermediate acting, which is NPH, and then 30% is your short acting or regular. So if you look at this relative insulin effect in the x-axis versus or y-axis versus the time in hours on the x-axis, you'll see that both of these insulins peak, with short peaking at about 3 hours and intermediate peaking around 7 hours. So if you're taking your morning dose of insulin at 10 a.m. and then you're taking your evening dose of insulin around dinner, maybe 5 p.m. or 6 p.m., you're going to, over time, stack all those insulins on top of each other and ultimately lead to hypoglycemic events, especially if the patient is also taking their sliding scale insulin as well, which typically we try to match with the same type of short acting that's in whatever they're using. So if they're using a rapid acting, we usually use a rapid acting short for a sliding scale. If they're using a regular, we typically use a regular for their sliding scale insulin. It just makes things a lot cleaner. you want to switch him to basal bolus insulin. So now we're going to do a little bit of math. The patient's weight I'm giving you is 75 kilograms. Can anybody calculate his total daily dose of insulin, keeping in mind his acute kidney injury? Do you guys want to see the previous slide for insulin dosing with renal failure? Or does anyone remember the dosing?
They are requesting yes to see.
There we go. I don't know if you guys were expecting to have to do math during this talk, but I find that when you have to do it yourself, you learn it. And so if you're forced to calculate it yourself, then you'll learn how to do it, and it will stick more so than consulting endocrinology or whatever other services might be available to you. So, oops, sorry guys. Okay, so we're gonna call.
So we have 15 units for
Solidly
basal
here,
based on
right?
that. Yeah.
Yeah. Okay, so let's go back to the case. So, okay, so 15 units total daily dose, right? So not basal. Remember, the calculation, the 0.2 units per kg per day is total daily dose of insulin. So it's actually going to be 7.5, which you can round up or down, of the basal, and then 7.5 of prandial, meaning that you're going to have to take that 7.5 and divide it by 3. So that's going to be about 2 to 3 units of short acting per meal. And you might consider switching this patient. I would, because if this was a patient coming into my clinic, I don't do outpatient, but a creatinine rise of almost a point, I'd probably recommend to admit. But regardless, I think that this patient has a lifestyle that's basically failing premixed insulin. So I would consider taking that patient and transitioning them over to basal bolus insulin. So here are some special populations when it comes to insulin. We've sort of talked a little bit about chronic kidney disease. So steroid-induced hyperglycemia. In terms of inpatient, you're going to monitor for at least 24 to 48 hours after initiation of steroids. If your blood glucose is greater than 140, you're going to continue the point of care testing. Remember, that doesn't hit the 180 where you would actually initiate insulin. That's just that you're going to continue to monitor. You're going to initiate insulin if they're persistently hyperglycemic with a blood glucose greater than 180. Remember that different steroids have different mechanisms of action and different peak actions. So prednisone is going to peak in 4 to 8 hours. Sometimes that one's amenable to using intermediate acting because remember I told you NPH peaks at 7 hours. Or dexamethasone and other multi-dose if you're using Solu-Medrol or some other sort of prednisolone, something else, then you may want to use your basal prandial and correctional. The biggest thing on the boards that they like to go after is that steroids cause postprandial hyperglycemia. So what they're trying to get at is that you're going to want to add mealtime insulin to these patients when their blood glucoses are uncontrolled. CKD, high risk for hypoglycemia. We just sort of talked about how their diabetic end-stage renal disease patients are always commenting about how as their kidneys got worse, their diabetes got better. And so many stop needing insulin as CKD progresses. Remember that the A1C is often unreliable, and we're going to talk about that later on because I have a case. It's going to talk about alterations in the A1C. And then the final special population that we're going to touch on here is perioperative. So perioperative glucose, they want a lot tighter. In fact, the guidelines are saying 80 to 180. That's your perioperative period. Remember, inpatient with 100 to 180. And we're going to talk a little bit more about how and when you withhold these oral hypoglycemic agents. So put that in the back of your mind because I'm actually going to go through the different ones and when you would hold them. But suffice to say, as we talked about, you give 50% of your total daily dose of insulin. So basically, you're giving essentially the basal dose of insulin if the person's NPO. And or NPH, you're going to give half of the dose in the morning. Remember that targeting a blood glucose less than 180 is associated with lower risk of stroke and mortality. However, if you read any of the literature on hypoglycemia, we know that in the short term, hypoglycemia actually has an increased risk of mortality and morbidity in the hospital. So it's not as straightforward as one would think, managing blood glucose in the hospital. Episodes of hypoglycemia lead to longer length of stay. And more instances where the healthcare system has to interface with the patient, meaning that the patient needs rescue. And so more resources are being used when patients become hypoglycemic in the hospital. And so we're balancing that with the need to have appropriate blood sugar for surgery. So in internal medicine, obviously, we will get consulted for perioperative medical evaluations. This is part of that, is making sure that our blood sugars are controlled on the morning of surgery. Okay, case number 3. So this one has multi-parts. This is a very classic patient who presents to the emergency department with acute COPD exacerbation. She's morbidly obese. She has type 2 diabetes, COPD, systolic heart failure, and CKD stage 3A. At home, she takes U500 insulin as an outpatient, but she's not always compliant, and her last A1C was 10.5%. Other medications she's on is metoprolol, aspirin, spironolactone, Lasix, sacubitril, valsartan, and tiotropium. Her blood glucose on admission or presentation to the ED is 325. She gets 125 milligrams of IV solu-medrol in the emergency department, turns around, and they send her home with Pred 40 for 5 days. Her other labs, when she's in the emergency room, are within normal limits, except for the blood glucose of 325, and she is at her baseline creatinine of 1.6. When she gets home, she calls you in the clinic because her blood sugars have been consistently greater than 500. So what do you want to do for this patient? And so she's now home. She's got her Pred 40 and her other treatments for COPD exacerbation, her doxycycline and her inhalers, and now she's at home.
We're getting a temporarily increase the insulin for the duration of prednisone to cover against that hyperglycemia. Also, a suggestion to confirm adherence to insulin.
Mm-hmm. Would anybody tell her to go to the hospital? I think you could go either way. I think you greater than 500. She can't read it. It's not even registering. Some would take it to the hospital. I agree. One, you gotta make sure that she's actually taking her insulin right, because I had said in the stem that she was not adherent to her, and the fact that she's already on U500, which we're going to talk about in a second, makes you pretty much know that she requires a lot of insulin, and she's obese and she has high insulin resistance. So it may not have been the best move to send her home after giving her solu-medrol with a blood glucose of 325. This is definitely something that could have been predicted, I think, at home, that was going to occur. Does anybody know what U500 insulin is?
One answer, not quite, but bringing up the idea of an insulin pump.
It is not an insulin pump. I am bringing this up too because this is a unique type of insulin. And again, just having awareness and knowing what it is.
Yeah, so other answer is highly
I
concentrated.
don't like it either, and I just stop it when they're because that's the recommendation by the ADA, which we're going to talk about. But yes, it's a highly concentrated insulin. So it's 5 times. So ever put that, Jay, yeah, normal is U100, right? So 100 units per ml in their little vials, right? So if you drop an ml, you have 100 units. Now this is 500 units per ml. So patients will be on this, and typically this is given by endocrinology, that they will put them on this when they're on greater than 200 units per day of insulin. Keeping in mind that it is very difficult to inject yourself with the volume of insulin, and so this is where the U500s came about. Highly concentrated, high risk of misuse by patients, and high risk of misuse by healthcare workers. So we recommend that they are not used. ADA says don't use them in the hospital because most of the time, most nurses have never heard of them and don't use them and don't know how to use them or dose them. And most providers don't know how to dose them. But I mean by dosing with the nurses, I mean by administering the correct dose because it is so highly concentrated. So dosing errors are very common. And remember that when patients get admitted to the hospital or they're sick or they're coming to you for whatever reason into the clinic because they're doing a sick visit, their blood sugars are going to be all over the place and they're not going to be reliable. So it's definitely something that we highly recommend endocrinology manages U500 insulin. And if you ever encounter somebody on U500 insulin, it should prompt a thought that this patient is very highly insulin resistant or they were non-adherent with their original insulin dosing. And so all that'll need to be teased out before escalating any doses for the patient. Okay, so she's on U500 insulin, but just for more practice, let's calculate her basal bolus insulin regimen. She's 112 kilograms and she's highly insulin resistant. Do you guys want to see the scale again to see what you would use for her? I think this is going to shock you. If you want to see the scale, let me know. I can pull it back up.
We have 56 units. We have an answer. And another saying 0.6 units per kg for obesity and steroids, but then bringing up the CKD may lower it to 0.4 or 0.5.
Yeah,
Another number we have is 45. Sorry,
45.
go ahead.
I think you could, depending on which one you used, between 0.4 and 0.6, you're going to get any of the above answers. But honestly, she might be the only one I would go to 0.6, right? With all of her comorbidities, she's on prednisone for a short period of time. I know that she has CKD, or start at 0.5. If you take her to 0.6, it's going to be 67 units. I know. A whopping, right? So didn't I tell you that U500 is usually used if patients have around 200 units per day of insulin? So this makes you think that maybe this patient really isn't using their insulin. They're not adherent to their insulin and they're not using it properly. So this is definitely a patient where you would want to have that conversation with them, right? So again, just to finish up the dosing, if you're using 0.6, it is 67. Again, you're going to divide that by 2, so that's 33 units of basal. Divide 33 by 3, that's 11 units of aspart plus a sliding scale, and you probably have her on a pretty aggressive sliding scale. And we don't know if that will cover her or not, right? This is one of those patients where you know that she's been non-adherent, you know the A1C is uncontrolled. And so this is somebody who you may recommend for admission to the hospital just for hyperglycemic control in a monitored situation to find out what does she really need in this setting. Okay, so 2 days into the hospitalization, blood glucose levels are greater than 200. Let's say you did recommend to admit. So what would you do to recalculate? How much do you increase the insulin by if they're still not at goal? 20% is fine. I think she'll tolerate it. It's between 10 and 20% you can increase. So remember, you're increasing by total daily dose, and then you do your division again. So you're going to take the total daily dose, increase that by 10 to 20%, go from there. The other question made me laugh. Increase her by 200%. But okay, so we're kind of talking about, let's say you either admitted her because you decided that's what you were going to do and now she's ready to go home, or you were a wizard and able to manage this in the clinic in conjunction with endocrinology and she didn't need to get admitted. So I'm going to go back to the case because I want you guys to look at this and say, what other medications is she not on that she should be on? Because to me, there are three that stick out. I think this is going to be a sticking point on the boards. They're going to want you to know. So what do you think? She has these medical comorbidities. She's currently on metoprolol, aspirin, spironolactone, Lasix, Entresto, and Tayo. Tayo is for the COPD. Yes. Okay. So she definitely needs to be on SGLT2. Let's go back here. So SGLT2, what else would you maybe think about with her? Yep. A GLP-1, absolutely, right? She's obese. She meets like 4 different indications for a GLP-1. Something that'll help sugar, kidney beans, and heart at the same time. Do we have those medications? Do they exist? Well, in matter of fact, they do. So let's just talk a little bit about some basics here. We went really deep into the inpatient management. I want to take a small step back into medication escalation in diabetes because I think this is a really important point. Remember that any board question is lifestyle modifications until proven otherwise, weight loss to achieve clinical goals. So 1 and 2 are, or if they're available, it's probably going to be the answer. And then I'm going to show you the current algorithm by the American Academy of Clinical Endocrinologists it's busy, but I just want you to keep it in mind. But this is how you escalate dosing in patients with diabetes in your clinic. Remember that what defines diabetes is a hemoglobin A1C greater than 6.5. So your goal is going to be, if you can, get it to less than 6.5. Remember that in our elderly patients, anything less than 8, I'm okay with. I mean, I'm a hospitalist, so to me, a 7.5 is fantastic. But again, I'm not monitoring them in the long term. And in the outpatient setting, again, you're going to avoid therapeutic inertia, meaning that you're going to make sure that you're getting them to goal, but you're also making sure, like with this patient, that they're being adherent to their medications. Continuous glucose monitoring is highly recommended to reach glycemic goals in adults with diabetes. This has been updated in every guideline over the last several years. So every patient that you have diabetes, especially if they're not controlled, should be on a CGM. And then again, the complications and medical comorbidities. So we're going to talk about that. That's what this slide is. And this is the most up-to-date algorithm. This was released in 2026, April, by the AACE. And so this is the most up-to-date in terms of glucose-centered glycemic control. When we're talking about, this is very similar to the beginning of this talk when we were talking about how we're targeting our dosing of insulin is basically based on who the patient is, how much do they weigh, and what are their medical comorbidities, right? And what's our target? Do we have a different target for A1C based on their age and their lifestyle goals and their goals of care, right? So again, looking at this, remembering that where the patient presents to you and what they bring to the table. Do they already have heart failure? Do they already have chronic kidney disease? Have they had a stroke? Do they have metabolic associated liver disease? So thinking about all of those things and kind of individualizing. Again, typically if somebody's A1C is greater than 9, you're going to start basal bolus insulin on them and then add other medications to that. If they have a high hypoglycemic risk, you're going to start with your metformin or your SGLT2 inhibitors. Again, our magical GLP-1s, overweight or obese, plus diabetic, you're going to go straight for those. And again, not forgetting about our glipizide and our metformins. They're cheap and patients can access them pretty easily, right? So, we all want to jump to these fancy other medications, but keeping in mind that the old medications still work and are still part of the algorithm. So I kind of alluded to this. So what about the non-insulin diabetic medications, anti-diabetic medications? So our Jardiance, don't ask me to pronounce the generic, unless you want to laugh, in which case I'll do it. It's like me trying to pronounce all of the monoclonal antibodies that are available for all the cancer treatments. It's a bad look. So this is our Jardiance-like medications. Again, when we're talking about SGLT2s, remember if they have heart failure and there are no contraindications, then you can actually start them. If you have a patient that's admitted to the hospital and then they come out, they may be discharged on those. This is one of the few, they are all made up words, or they're like combinations of two investigators, or who knows where they're coming from, right? SGLT2 inhibitors are not recommended for glycemic management in the hospital. Again, everybody by the ADA, AACE, Society of Hospital Medicine, you're transitioning everybody to basal bolus insulin or sliding scale insulin. But as we're approaching discharge for hospitalists, we think about adding these medications back 1 to 2 days prior to discharge, just to make sure that they're tolerated and you're obtaining a prior auth and making sure that they get approved. In terms of, I mentioned earlier that I was going to talk a tiny bit about perioperative, because we're all going to do this, whether we do this because the patient's admitted to the hospital or whether we do this because our outpatient is going for a surgery, we're all going to be doing perioperative medications and management. And all of our patients now are on some of these medications. I mean, the majority are on some of these medications. So SGLT2 inhibitors stop 3 days before scheduled surgery, 4 days in the case of Steglatro, and ensuring factors for ketoacidosis are resolved prior to reinitiating therapy. What does that mean? So if a patient is malnourished, not eating, septic, has an acute illness, whether that be any sort of exacerbation of chronic conditions that's making them catabolic, or then they're at very high risk of having ketosis and going into euglycemic DKA with these medications. So just make sure that if that's the case, that you are stopping these medications, especially prior to surgery when you know they're going to be fasting. GLP-1s, use of them on the inpatient is still in the research phase. We were laughing that they can do anything, and I think that there's been a lot of different research in different arenas about what these different medications can do. Where we're not really up to speed is that there isn't that much research yet about how they fare in inpatient setting. So all of them should be held if your patient's getting admitted to the hospital. Again, remember that they have a functional gastroparesis. It depends on the dose. Not all patients get it. So the original guideline, which was actually delivered, I think, in the early 2020s, these medications have been around for a long time. But the FDA added a warning label to all the GLP-1s and GIPs, talking about the risk of aspiration during surgeries and procedures. And so they were recommending that patients hold them. But now multiple societies and expert groups have advised a personalized approach. So this is really looking at your patient's individual risk, so that they already have gastroparesis from diabetes at baseline. Then you're going to have them hold it and go on a liquid protocol for 24 hours prior to the procedure. Again, some of these are weekly doses, so you may just have them hold their dose that they would be due for the week before surgery. And now that we have the oral formulation, and that one I don't think has been studied in some of these, but I would say that I have seen a lot of complications from GLP-1s in terms of just patients being admitted with pancreatitis, malnutrition, weight loss, electrolyte abnormalities, nausea, vomiting. And so my recommendation would be to hold them for surgery. But I think that's also, just as anything in medicine, a case-by-case, individualized basis. So a little bit more on GLP-1s. I don't know if you guys got this in your previous lectures or not, but the big trial that most people quote is the Surmont trial. It was conducted over 3 years. There are about 1,000 adults with prediabetes and obesity, and remarkable 94% reduction in progression to type 2 diabetes versus placebo, and up to 22 to 23% body weight loss over 3 years. Nearly 99% remain diabetes free at 3 years. We do know that many patients come off of these medications due to intolerance over time. Other indications that you may not know about or be aware of in the outpatient setting is Mounjaro was approved for moderate to severe sleep apnea. This was done by the same Surmont investigators. This is called Surmont OSA. All of these will be linked at the end of this talk, which expands its role beyond glycemic control and weight loss. So you can use this if your patient's not diabetic. That should get approved because of its indication for sleep apnea. Talking about Ozempic, again, January 28th, 2025. Somebody alluded to this in the Q&A. This is the big phase 3 FLOW trial that showed decreased progression of chronic kidney disease and cardiovascular death and type 2 diabetes in patients who are placed on Ozempic. This can be used to get Ozempic covered again in patients with elevated blood sugars that are not in the diabetic range. Semaglutide, another study that was done. This is probably my favorite indication, though I mean, we could roll the dice, but this one's my favorite. So this was a study that was done looking at people with alcohol use disorder who failed naltrexone, failed gabapentin, failed clonidine, failed therapy, failed everything, and they were put on low-dose semaglutide. And they had a decreased risk of cravings, and they had better drinking outcomes. So I got this approved once for a patient with alcohol abuse disorder and diabetes, but the diabetes was what it got approved for. So I think that there's more to come on this. More studies are being done, but this is probably my favorite indication for GLPs. That's not going to be on your boards, but I just think it's really cool. Okay, nobody said a statin. So no one said statin, maybe because you guys already had your CVD risk, but the last medication for this patient is a statin. Can you believe that obese patient was not on a statin? So remember, statin therapy in diabetics, always age 40 to 75. If you have a patient that's younger or older, again, this is a case-by-case basis. Moderate intensity statin for primary prevention, doesn't matter what their LDL is, just put them on a moderate intensity statin if they have diagnosis of diabetes and they're between the ages of 40 and 75. 40 to 75, high intensity. Primary prevention, regardless of LDL level, again, so same thing as above, but they're hypertensive, they smoke, they're obese. So they have these other medical comorbidities, and you're going to jump up to high intensity statin. Sorry for the typo, it's not AGRAS. 40 to 75, if they have ASCVD existing, always high intensity statin, and then you have a target 50% reduction, LDL less than 55. Again, young streams of age is going to be a case-by-case basis, although I think more of our young people, if they are obese, are going to be placed on statins. Final case. You guys should know the answer to this one based on the previous 2 slides. So 47-year-old diabetic male, fever, nausea, vomiting, right leg pain, right lower extremity cellulitis, admitted to the hospital. Blood glucose is 200, sodium is 134, bicarb 15, chloride 95, Case 35, albumin is 3.5. UA has ketones. He's a type 2 diabetic, and he's on 20 units of Lantus at night, and Jardiance was recently started about 1 month ago. Get out your calculators. What is this patient's anion gap? Thinking about what could this be? What would you want to order? And what do you think the most likely diagnosis is?
And we may want to go back to the other slide.
Yeah, this is a hard one. This requires some math and some ingenuity. think that's not one to, oh dear, I gave the answer away. That's okay. It's late in the day. Yes. So NI-gap is 24, 25, depending on which algorithm you use, but it's high, right? It doesn't matter. It's high. Euglycemic DKA, absolutely. What did I tell you in the stem that he had just started Jardiance? He's coming in. He's septic from a right lower extremity cellulitis. And the blood sugar is not that high, right? What additional testing might you want to order? And for time's sake, I'm probably just going to give you guys the answer because there's one more little part to this case that I really want to get into. So yes, beta hydroxybutyrate and an ABG. So I would get both of those. He has ketones in his urine. So, he's having some ketosis already. And so, yes, this is euglycemic DKA. It can be associated with a variety of factors. Again, we talked about being very catabolic, malnourished patients, pregnancy, alcohol use, liver disease, and or SGLT2 inhibitor therapy. So approximately 10% of people who have a history of diabetes and experiencing DKA is actually euglycemic DKA, which means the glucose is less than or equal to 200, and the presence of ketosis and metabolic acidosis, which this patient had. So DKA in and of itself, which we don't have time to talk about, requires either the presence of hyperglycemia or a prior history of diabetes. Now, the name is kind of misleading because some of these patients in the absence can develop a ketoacidosis, right? A euglycemic ketoacidosis. So it doesn't necessarily mean that you have to be a diabetic. So the name is a little bit misleading, but of course, this one is related to a patient who is a diabetic and it's on SGLT2 inhibitor therapy. So upon discharge, you are the person assuming the patient's care. You take a little bit more history from the patient and you find out that they have been a type 2 diabetic for 5 years, but the A1C has been increasing over the last year. Again, I told you he was on 20 units of Lantus and Jardiance, and the last A1C was 9.5. However, he hands you his glucometer, and all his blood sugar levels that he's taken at multiple different times a day have been between 100 and 150. He checks his blood sugars fasting and before meals. His BMI is 22. So what A1C level should correlate with a glucose level between 100 and 150? And what do you think that could explain the discrepancy between his A1C and blood sugar levels? Yeah, you're right. Between 6 and 7. So his blood sugar should be between 126 and 154. And I told you his A1C was 9.5, right? So what do you think could explain it? What could explain? What time of day is he not checking his blood sugars? I said he's checking them fasting and then before meals. And what isn't he on? Yeah, so this is probably postprandial hyperglycemia. He's not on any mealtime insulin to cover for those postprandial excursions. And what kind of tool might help with that is recommended in the guidelines? We talked on it a little briefly. Yeah, a continuous glucose monitor. So again, that's going to be hit home. They're recommending that for all diabetic patients now at this point. So continuous glucose monitor would help this patient to know what is causing his blood pressure to spike or blood sugar to spike and when it's happening or a pattern, right? So one other thing they love on boards is what alters the hemoglobin A1C. This is the last slide. This patient could have that, I suppose. So remembering that these are the conditions that alter the A1C, so hemoglobinopathies, increased red blood cell turnover, hemodialysis, EPO therapy, and decreased RBC lifespan. So remember that shortened survival, so these short, small survivals of the RBCs or the increased turnover will falsely lower your A1C. So those patients you may think have better diabetic control than they actually do. Again, a lot of this is going to be different now that we have those continuous glucose monitors that can be downloaded and you can get all that information from the patient. It takes a lot to move diabetes. There's a lot of references here. These are all pretty much primary papers, and they're great references. So for all different walks. And that is the end of my talk. I think we have 15 seconds, which was pretty good. I don't know, Dr. Shenoy, I talked a lot.
It's great. We do have a question. If you can touch on the side effects from the GLP-1s, and particularly what we might see in older patients when they get that weight loss, in terms of thinking
Yeah.
about, things you've seen like muscle mass, bone density, and of course the GI.
So there's a couple things here. There's been some studies. So when we're thinking about putting patients on GLP-1, remember that we're not talking about putting people, let's talk about different patient populations. So first patient population I think about in older populations is your menopausal population, right? So your postmenopausal population, you get a huge decrease in bone density, huge decrease in muscle mass. However, they are doing studies that they have with patients who are in menopause, who they've been putting on GLP-1s to decrease visceral fat. Now, I think that these are newer studies. They're looking very promising. So, but you have to balance that with the fact that, you have to choose the right patient, right? So patients that are thin could still have high visceral fat. So my best way to get at that is probably a DEXA body scan to see where your visceral fat is to begin with and see if you really are having a problem. And that'll also give you a generalized bone density, but you could also just do a DEXA, a general DEXA. But I think that in terms of those studies, they are looking promising in terms of reducing visceral fat, but I also think that you have to balance that with weight training and increasing patients' ability to exercise, because we do know, as you alluded to, that a lot of the studies have shown that this does decrease the body weight and it decreases muscle mass and decreases bone density. And in fact, all the studies that have been done with just the GLPs alone have shown a decrease in muscle mass. Now, the studies that have shown that paired with weight training, they don't show as dramatic of an effect. So you're really going to have to counsel your patients. This is going to be, you need to pick up 100 pounds, and that's very intimidating to patients, right? So it's going to have to be, I think we're going to see a lot of changes and hopefully a lot more guidelines and guidance for clinicians when we're prescribing these medications, because they are not without risk. And they are not without huge benefit. So you don't want to eliminate them, but you want to make sure that you're telling your patients to prioritize protein, fiber, and to prioritize weightlifting, and prioritize preserving muscle mass and bone density if they are going to be on these GLP-GIP combinations or the GLP medications. I'll have to get the reference, the studies that I'm referring to. Maybe I can send them to Liz. There's a couple of them. They're great. But again, we need more time and probably more data too.
Thank you so much, Dr. Renzel. This was great, and really appreciate everybody's participation and hanging with us through this busy week. So just for some concluding thoughts, again, I want to thank all of our speakers, and direct everyone to keep an eye on the course website. The slides from all the speakers will be going up, as well as the recordings. For the talk yesterday, the nephrology talk, where our speaker had unfortunately something very acute come up, we may ultimately use the talk from last year, potentially. I'm not sure if Dr. Ray is going to be able to do a recording for us in the near future. We want to make sure we have that content for all of you. And I think otherwise, good luck. Again, it's a big exam, but you have spent a lot of time preparing for it. And I don't just mean studying, because a lot of this is obviously going to come straight from all of your residency experiences. And you will have several different options when it comes time for renewal way down the road, which are less stressful potentially. And please feel free to reach out with any questions or any difficulties accessing any of the resources in the next month as you prepare for your boards.